Okay. Hello, everyone, and warm welcome to this webinar on the link between vaccinology and health economics. This webinar is the second in a series of planned webinars with the goal of providing information on available career options in the field of vaccinology. My name is Joy Kiptim. I am the Public Engagement and Communication Officer at the KEMRI-Wellcome Trust Research Program, and together with my colleague Caroline Mate, will be the facilitators for this session. Before we start, a few housekeeping matters. One is this session is being recorded. The recording will be publicly available on our website for 3 years post this webinar. We'll use this information for training purpose for the general public. 2, take note of the chat box option for those who are not conversant with Teams. If you're using a laptop, it should be at the top of your screen. If you're using a phone, it is at the bottom. The icon is a word bubble. Feel free to use that chat option to share your questions during our presentation, and we will address them during the Q&A session. Finally, we have a few open slots for people to directly ask questions to the presenter. If you have stable internet, and if time allows, kindly raise your hand, and the backend team will give you control to your microphone, and you'll be able to ask your question. I would like now to hand over to Caroline to give us a brief intro to the program and the project that hosts this webinar. Over to you, Caroline.
Thank you very much, Joy, and thank you for all the participants. Good morning, good afternoon, good evening from wherever you're logging in, and a warm welcome to this webinar on vaccinology and health economics. My name is Caroline Mate, and I am the Program and Strategy Manager at the KEMRI-Wellcome Trust Research Program. As my colleague has mentioned, this is a series of planned webinars with the goal of providing information on the available career options in the field of vaccinology. This is by the KEMRI-Wellcome Trust Research Program, which is a world-renowned health research unit of excellence based in Kilifi and Nairobi in Kenya, as well as Mbala in Uganda. Over the years, we have excelled in the use of novel ideas and collaborations to achieve better health for Africa while developing African scientific leaders. Our vision at the program is to undertake cutting-edge, impactful research that is relevant to national, regional, and global needs. So our vaccinology workforce development program aims to expand the technical know-how and capability of sustainable end-to-end vaccine research and development and manufacture in Africa through training and knowledge exchange activities in the vaccinology ecosystem. And how we are able to do this is through 3 approaches. One, by supporting apprenticeships for African scientists who are then attached to human vaccine manufacturing facilities globally. The second way we do this is by running annual master level courses in vaccinology that ends up giving a deeper dive understanding of vaccinology. And the third way we do this is by conducting regular webinars such as this for university students and early career scientists in Africa, so that they're able to increase knowledge of vaccines R&D as potential career paths. So this program is aligned to the African Union Partnership for Africa Vaccine Manufacture ambition, which is to increase the local vaccine production to meet at least 60% of Africa's routine immunization needs by the year 2040, and also strengthen the capability of the vaccine research, discovery, and manufacture in Africa. So today we have the great honor of hosting one of our very good professors, Professor Edwine Barasa, who will be discussing the links between vaccinology and health economics. I will give a brief bio of our speaker and then hand over to him. Professor Edwine Barasa is the Deputy Executive Director of the KEMRI-Wellcome Trust Research Program and head of the Health Economic Research Unit. He is also a visiting professor of health economics at Oxford University with research spanning health financing, the efficiency and equity of health systems, the economic evaluation of health interventions, and translation to policy. He also serves on multiple international, regional, and national boards. Here in Kenya, he is the chair of the Africa Universal Health Coverage Commission, He's also the Africa CDC Working Group Health on Health Technology Assessment and the Africa CDC Health Economic Programs Advisory Board. Over to you, Professor.
Thanks, Caroline, for that introduction. I hope people can hear me. So the idea for today is to really try and make the link between economics, and specifically health economics, and vaccinology. It is meant, as Caroline has mentioned, it's meant to be a career webinar, the idea is to really highlight some of the potential career options or career tracks that people can think about in vaccinology, but from a multidisciplinary lens. And so the lens you're going to apply today is economics or health economics. So I will attempt to do that. As you can expect, it's not going to be exhaustive. So the idea is just to give a flavor of what is out there. So I'm trying to move my slides. Caroline, my slides moving?
Yes, they are.
Okay, great. Thank you. So I'm going to talk about three things, clustered around three things. One, a little bit of a primer or a background on economics and health economics as a context upon which we will then begin to think about vaccinology. So I'll talk about economics and health economics. I'll talk about this concept that we call market failure, and then use that to look at vaccines and vaccinology. So one of the things that as economists or health economists we concern ourselves with is that, or the reason that the profession exists in the first place, is because there's an economic problem of scarcity and choice. And this quite simply means that resources are scarce, and the needs that should be fulfilled by these resources are unlimited. So you have more needs than the resources that are available. And because you have more needs than the resources that are available, then countries and individuals have to make choices about what to allocate resources to. So you have scarcity, you have unlimited needs, and so you have to make choices at any one time. Individuals have to make choices, countries have to make choices, firms or organizations have to make choices about which choices about where to allocate the scarce resources that they have. And so economics is really a science that studies how people make these choices. How do people make choices about allocating resources to satisfy needs and wants that are unlimited? So if it's a country, for instance, a country has a budget, the country has multiple needs across sectors. Within the health sector, you have multiple needs. You have to think about financing care across, communicable, non-communicable diseases, several interventions within those, and so on. So the needs are unlimited, and yet the budget is limited. And so you have to make choices about how to allocate those resources, and that is what economists study. Because if you make a choice to allocate to one need, it means you're not allocating to another need. So you're foregoing another need. And so what is the implication of doing that? So that is what economics is, and health economics is when these principles of economics are applied to the health sector. And one of the questions that people typically ask is, why would we need, a field? Why don't we just, focus on economics? Why do we need a whole other field called health economics? And we will come to that. So we've said that economics is really about thinking about how to allocate scarce resources across competing needs and wants. A tool to achieve that a tool that is used to achieve that is the concept of the market. So essentially, a market is where those resources and the needs meet. and the way that you have interaction within the market determines how efficient resources are allocated. So ideally, economists assume that for there to be efficient allocation of resources, you would need a perfect market. And in a perfect market, you have you essentially have the forces of demand and supply interacting to determine the prices for the goods and services that are being traded and the quantities. Now, for the market to be efficient, then it needs, or to be perfect, it needs to satisfy certain conditions. The key conditions are that the market must be competitive. So, and by competitive, what we essentially mean is that you need to have in the market many suppliers of a good or service and many consumers of the good or service, so that you have competition. The other thing that a market would need to have for it to be a perfect market is that the market must not have any benefits or costs that are external to the market. So what this means is that if the reason goods and services are procured is because they have benefits. So the benefits should essentially be channeled to the people that are consuming those goods. And if you have costs for the production of the goods, then those costs should be restricted to the production of those goods. So you shouldn't have costs and benefits going external to the market, and we will come to that. And then the third condition of a perfect market is that the buyers and sellers should have complete information about what it is they're buying and selling, about the prices, about the alternatives that they have, and so on. So they should have perfect information. So those are three sort of key ingredients of a perfect market: that it should be competitive, costs and benefits should be restricted within the market, should not, or rather restricted to the producers and the consumers. They shouldn't spill over. And the buyers and the sellers must have or should have perfect information about prices, about the alternatives, alternative goods and services, and so on. But typically, what we have is that what we see typically is markets that are less than perfect, and the health sector is one of the sectors that is characterized by what we call market failure. So market failure occurs when the conditions of a perfect market are not met. So we talked about three conditions that a perfect market should have. Should have competition. It should have many buyers and many sellers. When you don't have that, when you have few buyers or few sellers, then you have what we call market control. So you have few people that are responsible for producing the goods and services, or you have few people that are responsible for consuming the goods and services. So those few people have control over the market. So that is a failure of the market. The other market failure that we have is what we call externalities, and we will come to that. And this is where either the cost or the benefits of producing or consuming a good or a services go beyond whoever is producing or consuming. And then you also have information asymmetry. So this is a situation where one party to the transaction, so either the buyer or the seller, has more information than the other. So you have an asymmetry of information, which can create its own challenges. And what happens when markets fail is that the outcomes of the market are either inefficient or unfair. And like I mentioned, the health sector is characterized by market failures. And this is really the concern of health economists, that the healthcare market or the health sector is characterized by market failure. And so we cannot expect we cannot expect the sort of traditional rules of economics to give us the outcomes that we would want in the health sector. We cannot expect that the traditional rules, such as letting the market allocate healthcare services and goods will result in an efficient health sector, or will result in an equitable health sector, because you have market failure. And so you have to think about how do you structure the health sector so that you overcome these market failures and you're able to achieve the goals of a health system that you're interested in. So efficiency, equity, quality, and so on. So that's really the kind of things that someone who decides to get into a career in health economics would be thinking about. And we will illustrate this using vaccines or vaccinology as an area within the health sector that really typifies market failure and the need to think to use economic knowledge and economic tools to optimize that particular market. So one of the market failures that we've talked about is market control. And as I say, this is where either buyers or sellers are able to exert influence over the price of the good that is being exchanged. So in a perfect market, the buyers and the sellers do not really determine the prices and the quantities, because there is competition, you have many buyers, you have many sellers. So no particular seller has a control over the price. They basically have to sell at the market price. That's what we call the market price. And no particular buyer, again, has control over the price. They have to buy at the market price because you have many buyers and many sellers. But in a situation where you have market control, where you have few people that are either buying or selling, then whoever is, the few that are selling have control over the price. They can set prices. They can set prices. And likewise, if you have very few people buying your commodity, then they can also set prices. So market control happens on both the supply side of the market and on the demand side of the market. On the supply side of the market, when you can have a situation where you have only one single seller, so only one person producing and selling a good or a service, we call that monopoly. And you can have a situation where you have very few sellers of goods and services, we call that oligopolies. On the demand side, again, you can have very few buyers of your good or service. When you have only one person that is buying your good or service, we call it a monopsony. And when you have a few, a handful of people buying your goods, we call it an oligopsony. When you think about, so that's an example of a market failure, few people controlling the market, either from the supply side or the demand side. Now, when we think about vaccines, we know that vaccines, they are biologics, they're quite complex to manufacture, so the technology is quite complex, the supply chain, regulation, all of this is quite complex, and the implication of the complexity in the development of vaccines is that it requires, the entry barriers to the manufacture or production of vaccines are quite high. So it requires a high capital investment. And the implication there is that then you end up in a situation where very few manufacturers, very few sort of private investors would invest in the development of vaccines because of the high, capital investment that is required. So you end up in a situation where very few pharmaceutical companies globally manufacture vaccines, and even fewer in Africa. And this was more prominent during COVID. We will all remember that Africa faced quite a challenge because we do not manufacture vaccines locally. Again, vaccines are biologics, so you don't have generics, you have biosimilars. And again, it's quite complex and tricky to produce these biosimilars. And this, again, reduces competition. So when you think about other pharmaceutical products, once they are off patent, you can have the entry of generics, which introduces competition. It drives prices down, improves access, and so on. This is less, it's not as easy for vaccines because of the challenges with developing biosimilars and so on. So again, it reduces competition, and you end up with a situation where you have very few manufacturers getting into the vaccine market. So the market failure there is market control, where you have few people or companies manufacturing vaccines, and we call that oligopolistic power. And this comes with certain challenges. So there's an incentive for these few suppliers or manufacturers of vaccines to set prices with high margins. So the cost of new vaccines are normally quite high because of this, because you have few people that control can determine prices rather than the market determining the prices. The other challenge, of course, is supply side, supply constraints, especially during emergencies. We had the challenge with supplying COVID-19 vaccines because we had very few options available. And then you can also have underinvestment in the development of new vaccines. So particularly vaccines that are used to prevent diseases in low and middle income countries. And this is because low and middle income countries have a low purchasing power. So the market there is quite small. And big pharma would not be incentivized to invest in the development of vaccines when they do not have a guaranteed return on investment because of the low purchasing power in low and middle income countries, compromising their return on investment. So an example is you can think about the TB vaccine, for instance. I mean, I'm sure you've seen in the news that there's a planned trial, a phase 3 trial for a new TB vaccine, and this is after almost 100 years of not having, many years of not having a many years of having quite an old vaccine. So there hasn't been incentive to develop a new vaccine until now, and we'll come to how that was possible. So what you see here is essentially the market for the supply side market for vaccines. So vaccine manufacturing in globally is really just controlled by a handful of companies. So about 4 or 5 companies controlling 90% of vaccine production in terms of value and 60% in terms of volume. So just 5 manufacturers responsible for that. So some of the concerns that health economists would have, or economic concerns dealing with this kind of market failure, is how then, within this context, how do you incentivize the development of vaccines? How do you ensure that, how do you incentivize pharmaceutical companies to invest in R&D and in the development of vaccines for diseases that are mostly prevalent in low and middle income countries when the companies are not, manufacturers are not guaranteed or assured of their return on investment? How do you do that? How do you use the economic tools to make that possible? How do you ensure that these vaccines by these companies that they deliver market at an affordable cost? Because as you mentioned, when you have then you can set prices, and typically these prices are set at quite a high level, making them unaffordable. So how do we use economic tools or economic thinking to incentivize development of vaccines at an affordable price? So a number of strategies are commonly used to fix some of these supply side market failures. One is a provision of public subsidies for research and development. So essentially, rather than remember, in a perfect market, you essentially let the market determine what is produced at what price and what quantities. And typically, pharmaceutical companies will use their own private capital, so shareholder money, to manufacture, or rather to invest in the development of vaccines. But in a context where companies are not assured of a return on investment, then you have to think about how to incentivize them to do the R&D anyways and to produce vaccines. And one of the ways of doing that is providing public subsidies. So either from government or from philanthropies and so on. So funding the development of these vaccines so that you de-risk the development process. The thing about this is that, one, it incentivizes the development of these vaccines, but it might have its own challenges as well, because sometimes, so we call these push strategies, sometimes it might incentivize inefficiency. So overspending, for instance, because they're essentially spending funds that are not theirs. So you can incentivize overspending in research and development. And this is why economists have thought about pull strategies, so demand side policies that would stimulate vaccine research and development. Now, some of these include, for instance, what we call advanced market commitments. And these are essentially situations where manufacturing companies are guaranteed, guaranteed that once they manufacture they invest in and develop a vaccine, then those vaccines will be procured at a set price at the point at which they are, they have been manufactured. So it de-risks the investment, because pharmaceutical companies have a guarantee that they will be able to sell the vaccines at a specified price. And you can think about, for instance, during the COVID-19 pandemic, where several countries made pre-purchase agreements with manufacturing companies to develop COVID-19 vaccines. So that's one of the ways to fix some of these failures. Supply side, or rather push strategies in terms of providing public subsidies, and pull strategies or demand side strategies such as advanced market commitments. So again, these are examples. During COVID-19, some of you will be familiar with the US initiative to finance the development of COVID-19 vaccines. So Operation Warp Speed put in a lot of money to pharmaceutical companies to de-risk their development of COVID-19 vaccines in a context where there wasn't an assurance that the vaccines would work, there wasn't an assurance that there would be a market for the vaccine, and so on. So government had to step in to put money to pharmaceutical companies to develop the vaccines. We, again, if you've been keenly following the news, you would know that there's a TB vaccine that's going on trial, and this has been made possible by funding from two foundations. So funding from the Bill and Melinda Gates Foundation and the Wellcome Trust to support the development of this new TB vaccine after quite a number of years of very little research in the area. So that is one market failure that we've looked at, which is market control, and what it means for vaccines, and what it means for some of the economic concerns that someone who decides to get into health economics and to focus in vaccine economics can concern themselves with. The other market failure is what we call externality. As I mentioned, typically, when you eat a piece of bread, you benefit. The person seated next to you does not benefit from you eating a piece of bread because there's no externality to eating a piece of bread. But then there are certain goods and services that, when consumed, have effects that go beyond the person who is who's consuming it. So when that happens, we say that that's an externality. And externalities can either be positive or negative. So for instance, if you're seated next to someone who's smoking, you're not the person who's smoking, but secondary smoke is also harmful. And so that's a negative externality. When you vaccinate individuals within populations, you get herd immunity. And so you have a situation where individuals that are not vaccinated benefit from the protection from the vaccine, even though they haven't been directly vaccinated. So we call that a positive externality. So externalities can be positive or negative. So in the case of vaccines, herd immunity is a positive externality, which is a good thing, but it does present certain complications, as we will see later. Does present certain complications that amount to market failure. Externalities can also occur, in the production of goods and services. So not just in the consumption, but also the production of goods and services. So for instance, if you have a factory that's producing whatever goods and services, it can cause pollution, which, to the environment, which is a negative externality. Now, the challenge with externalities is that if you have positive externalities, some of those benefits are usually not captured and included in the price. And if you have negative externalities, they are not captured and included in the costs. So that introduces inefficiencies within the system. So what does this mean for vaccines, for instance? When you think about vaccines, it's private demand. So that is you as an individual, whether you would want, you take up the use of a vaccine or not. And then there's public demand, so this is at a more population level. When you think about countries, for instance, procuring and deploying vaccines to their population. So when you, at the level of private demand for vaccines, some of the challenges is that, vaccines are typically used on healthy people rather than sick people. And as you mentioned, vaccines benefit both those who are vaccinated and those who are not vaccinated, herd immunity. And that the challenge there is these are externalities. And what that then means is that people have very high sensitivity to things like safety, convenience. So something like the convenience of administration, the discomfort of administration, people have very high sensitivity to it, the cost, cultural and religious concerns and so on. And this leads to vaccine hesitancy. So you have a situation where market failure, which is externalities lead to vaccine hesitancy, and it's quite easy for someone to opt out of taking a vaccine because they might still benefit because people around them have taken the vaccine. So you have what we call a joyrider effect, which creates a challenge because if everyone thinks like that, then no one gets vaccinated and so on. And again, we saw that with the low private demand for COVID-19 vaccines, especially amongst people who are perceived to be low risk. With regards to public demand for vaccines, again, so the demand side of the vaccine market is characterized by very few buyers. So on the supply side, we said very few suppliers, so you have very few companies, a handful of companies that produce vaccines. On the demand side, you also have a challenge. You have very few buyers. So most vaccines are procured by governments rather than by individuals. And by nature, governments are fewer. So if you're going to come into Kenya, for instance, your biggest market is going to be the government of Kenya, which is one person, pretty much. It's one buyer. So that does create a challenge. And then in low and middle income countries, certainly in quite a number of countries in Africa, vaccines that procurement is handled mostly by UNICEF. So again, a few people procuring and funded mostly by Gavi with some government contribution. So Gavi, the Vaccine Alliance. So again, you have a problem there because you have very few people that are that are on the demand side. So this is monopsony or oligopsony power. And the challenge with that is that when you have few buyers that you're dependent on, then they can push the prices quite low and to the extent that it is lower than the cost of production. And the challenge with that is that then it disincentivizes the producers of the commodity. So it disincentivizes the producers of vaccines. So when you look at the global market, I think the last time I checked, the global pharmaceutical market, out of the value of the global pharmaceutical market, vaccines account for only 3%. So clearly tells you that pharmaceutical companies make most of their money producing other pharmaceuticals as opposed to vaccines, and it might be the case that there's that disincentive to do that. So you have to think about how you address that kind of market failure from the demand side of things as well. So in terms of some of the concerns that an economist might have include, for instance, how do you incentivize or improve the private demand for vaccines? How do you get people to actually take vaccines in a context where they feel that they shouldn't because of externalities such as herd immunity? How do you finance vaccines for low and middle income countries? Vaccines can be quite expensive. Low and middle income countries have very constrained sort of funding envelopes, and yet they need to invest in vaccines. So how do you structure financing for vaccines? So with regards to some of the solutions to sort out the demand side of demand side market failures for vaccines, at the private level of demand, again, subsidies of providing subsidies at the point of access to vaccines. So in most countries, vaccines are provided for free. So lowering the barrier to access the vaccines increases the demand for vaccines. Advocacy and awareness, so sensitization and so on, and mandates, making it, for instance, mandatory that people have to get certain vaccinations. And countries have experimented with this. There are countries where, for instance, children need to be vaccinated for them to be admitted to schools. You have countries where you have to have certain vaccines if you are to enter the country and so on. So mandates are a strategy to ensure that private demand for vaccine is driven up. With regards to public demand, pooled procurement. So we have mechanisms that ensure that you essentially aggregate the demand from the few buyers so that you have many buyers and you benefit from improved efficiencies, better prices, better negotiation, and so on. And then some of the other strategies include, structuring international financing or funding mechanisms. So Gavi, for instance, supporting the financing for vaccines in low and middle income countries. And during the COVID-19 situation, we had mechanisms for financing and procuring vaccines globally, such as AVAT, that was for Africa, coordinated by the African Union, and of course COVAX, that was coordinated globally. So those are demand side and supply side market failures and the questions that they present in terms of challenges and some of the concerns that a health economist would have, and some of the solutions for those challenges. At the health system level, countries have to make certain decisions. So countries have to make decisions, for instance, around whether they should allocate scarce country resources to vaccines. We have to make decisions about what vaccines, if they're going to invest in vaccines, what vaccines should they publicly finance for the population? So what vaccines should countries put their government budgets on? And how do you do it? Where do you get the money as a country? And how should the vaccines be delivered? Because there are several delivery options or delivery strategies for vaccines from the point they're procured to the point that they get to a child's arm. So these are some of the decisions that health system managers and policymakers have to make, and some of them have economic implications. One of the key questions that policymakers ask themselves is, what is the value of vaccines? And here by value, we are talking about the health benefits and how to maximize those benefits within a given resource, with the resources that are available. So a tool that we use as health economists is a cost effectiveness analysis, basically economic evaluation. And there are different types of economic evaluations. One is a cost effectiveness analysis, one of the most common one, which is a comparative analysis of alternatives, healthcare interventions, considering both their costs and benefits. And the idea is to identify those interventions that yield the greatest health benefit for the resources that are available. Cost benefit analysis is similar to a cost effectiveness analysis, except that it converts the health benefits into monetary terms. So it converts the benefits into monetary terms so that you compare money for money rather than health outcomes directly with money. So the idea for cost effectiveness analysis is when you're faced with a choice, so should we take in or adapt a new vaccine as a country, as an example of a choice, then that is that's intervention A, where you have the vaccine, and then intervention B, where you have the current situation, and you compare both of these alternatives in terms of their costs and in terms of their benefits. And what's generally been found is that vaccines are one of the most cost-effective interventions, public health interventions, and this is just an example of an analysis that was done to look at the economic value of 10 vaccines across 94 countries. And what you see in the second row there is essentially the return on investment across the 94 countries. And essentially what this means, for instance, is that when these countries invest $1 in these in the 10 vaccines, they get back about between $43 to $47 dollars. So in terms of broader economic benefits, so quite high return on investment, demonstrating the value of vaccines and the need to invest in vaccines. And of course, this kind of analysis can be done for individuals or single vaccines. Beyond decisions around whether we should fund vaccines or not, health economists can also contribute to decisions around how to deliver vaccines. Vaccines can be delivered in multiple ways. They can be delivered, for instance, through schools. They can be delivered through campaigns. They can be delivered, as part of outbreak response. They can be delivered through sort of routine immunization channels, in child pediatric clinics and so on. So different delivery strategies, and each of those delivery strategies determine the effectiveness and efficiency of delivery of the vaccines, and also come with different costs. So it's quite important to understand what the costs are for the delivery of vaccines and to inform decisions about what's the most optimal way to deliver vaccines. So those are just it's a flavor of some of the things that a health economist thinks about when they're thinking about vaccinology, or rather the relevance of economics to vaccinology more broadly. Thank you. Back to you, Caroline.
Oh, thank you very much. That was quite a bit of information for us to digest. And I am throwing it back to the audience. If you have any questions, just throw them into the chat box or raise your hand and ask them. But I'll start off with one question, Professor. Vaccinology, health economics, who is easier to get into whose space? Do you want to get an economist and teach them vaccinology, or do you want to get somebody in the vaccinology medical research and teach them economics? Which is easier?
So that's an interesting one, Carol. I don't think there's easier. I think either works. And I say this because if we put vaccinology aside for a moment and we look at the field of health economics, so the field of health economics has people get into the field of health economics from different disciplinary backgrounds. The people who get in as with an undergraduate degree in economics, and they then go on to get a master's or a PhD in health economics. And there are people who get in from health-based fields, so nurses, pharmacists, medical doctors, and so on. So they train in different disciplines, rather non-economic disciplines, and then they get interested in health economics, and so they get into health economics at postgrad level, so master's or PhD. So what that means, so for instance, I'm a pharmacist. I trained as a pharmacist. I didn't train as an economist in my first degree. So what that means, Caroline, is that someone who is a vaccinologist, someone who has a health-based background, who's then developed an interest in vaccinology, can get trained in health economics if that's what they're interested in. And likewise, an economist who is trained in health economics can develop an interest in the economics of vaccines, and then get that specific skills or competency and get on with their career. So I don't think either is easier or harder. I think it's just about interest.
Yeah, thank you for that. We have a question from Dr. Elijah Matolo. Do you want to unmute?
Yes, thanks a lot. My question is to say the biggest buyers of vaccines, usually are governments. I know during the COVID pandemic, we saw private sector coming together, pooling resources, and they were ready to purchase vaccines. That was a COVID vaccine. So coming back to HPV vaccine, which despite it having benefit for quite a range of the population, the government restricts it to just a 9 to 14 years old, because that's where you have the most benefit. Is there a room for, sort of having a similar initiative, having, government negotiating prices on behalf of maybe the private sector to get the good prices that will then enable the vaccines being made available to women or girls above the age of 15 years, and probably even boys. And I'm saying that because the vaccine is available locally, but the commercial prices, they're just completely out of reach for most of the population. Thank you.
Thanks, Doc. Caroline, would you like me to answer that? Or do you want to ask
Yes,
another
please.
one first? Okay, great.
Yeah.
So I guess, so there are 2 points there. I think you've raised 2 points. One is, what is the role of the private sector? So certainly in any market, and markets will vary, right? But in any market, you will have a private market, and you'll have, sort of the public sector market. So in Kenya, you have vaccines that are procured and delivered, procured by government, and you have vaccines that are procured privately. So you have those 2 markets. But the point here is the biggest market is is a public market. That's the biggest market, even though you have in most countries it's really at least the low and middle income countries, it's usually government. It's that's the biggest market. But that's not to say that the private market doesn't exist. And then secondly, it is quite possible for government to partner with private sector to deliver vaccines, and that's already happening for other routine vaccines. So if a child was born was born in a private hospital, they would get access to publicly financed sort of KEPI, rather EPI vaccines. The EPI vaccines. So it's possible for government to partner, and there's precedent for that. The specific case, you've talked about the specific case of HPV, so that's a policy question. It doesn't have an easy answer. You can't say, yes, this is what government should do. I mean, it should, it does depend on a lot of other things. But the point is there are mechanisms for government to partner with private sector to deliver any vaccine.
Thank you for that. I hope that answers your question. And there's a question on the chat box. If you could, Millicent is asking if you could kindly go back to the slide with cost effectiveness analysis, the comparative analysis, and explain that a little bit more for them.
Is this the one? So I hope this is the one. I'm not so sure.
Yes,
I hope this is the one. Yeah. So the thing here is, one of the ways to determine the value of a health intervention is to carry out a cost effectiveness analysis. And a cost effectiveness analysis is essentially it's a comparative analysis. It means you're comparing 2 or more health interventions or 2 or more alternatives. And you can compare them on various parameters. So for instance, you can compare them based on just effectiveness. So which of these 2 interventions is most effective? Or you could compare them based on safety. So which of this intervention is more safe? Or you could compare them based on cost. So which of these two interventions is less costly or more affordable? Now, what a cost effectiveness analysis does is to combine both the benefits and the cost. And this is what you see here, that if you have two interventions, so intervention A and intervention B, and you have to make a choice, then you measure the health benefit of intervention A, and you also measure the cost of that intervention. And likewise, you measure the health benefit of intervention B, and you also measure the cost of that intervention. That's what, that's a very sort of hyper summarized explanation of a cost effectiveness analysis. Because then once you've done that, is that then you have to develop a ratio. We call it an incremental cost effectiveness ratio, where you look at the differences in costs of the two interventions divided by the differences in benefits of those two interventions, and then you get a ratio. And an intervention with a lower ratio is more cost effective than an intervention with a higher ratio, because essentially it means if you have a lower ratio, you remember cost is your numerator and benefit is your denominator. So if you have a lower ratio, it means you're getting your benefit with a smaller amount of resources compared to an intervention where you have a higher ratio, which means that for you to get a health benefit, you're spending a bit more.
Thank you for that. I'll jump into the next question from Tabitha Okech. A very enlightening presentation, Professor Barasa. If vaccines have been shown to be generally cost effective, why do we still need to prove further by carrying out more CEA? Tabitha,
yeah, so that's
go ahead.
Yeah, I mean, that's an interesting question. I mean, so vaccines have, been generally shown to be cost effective, but generally, what does generally mean? It means you have to carry out cost effectiveness analysis for you have to do an assessment of every vaccine when you're presented with the decision to either fund it or not fund it. So that that's one point there. It doesn't mean that it's a blanket statement that every vaccine is cost effective for all populations. We have to keep that in mind. And then second, when we talk about choices, the choice is not limited to should we invest in a vaccine or not. There are very many choices. So one is, should we do it or not? Second is, for what population? You can have a vaccine, but then is the investment to deliver that vaccine or deploy that vaccine to what population? Should it be deployed to the entire population and all age groups, or should it be deployed to high risk population segments or all age groups and so on? So that again is a decision. So for instance, during COVID, there were questions around at the time, in a context of scarce resources, should COVID-19 vaccines be deployed to entire populations, or should they be deployed to high-risk individuals? So the question was not, do we need a COVID-19 vaccine or not? It was, what population should we focus on? And then the other is delivery strategies. What delivery strategies should we use? So there are many layered questions there. And certainly there are contexts where certain vaccines are found not to be cost effective.
Okay, so we'll jump to the next one. This is from Amina. I remember her from way back 2006 when we worked with her at DVI, which was a division for vaccine under the Ministry of Health. And her question is, thank you for the interesting presentation. I think the AMC and Gavi models have removed the donation mentality and pushed the responsibilities to governments to plan for their populations. Procuring vaccines for their populations have forced them to look at cost-benefit analysis and other economic analysis that guide them on investments against scarce resources. So that's a comment from Amina. The question from James is, this is quite enlightening. How can scientists sensitize African governments to invest in vaccine research and development, given the benefits? currently it looks like it's a private sector driven, mainly driven by the private sector. And maybe we can take two at a time. Kennedy is asking, how could African governments or countries contribute towards a reduction in vaccine inequity, given that in most instances, we only have to rely on donors, e.g. Gavi? So the two are related. Over to you.
Thanks. Quite interesting questions. I mean, I think one of the questions, and you can correct me here, one of the questions is around how do we engage governments or sensitize governments to invest in vaccine research? I think that's that was a question. I mean, this is obviously a problem, right? Especially in low and middle income countries, where research in general is underfunded. So it's not just vaccine research; it's research in general is underfunded, whether it's research in health or research in anything else. And then, so the health sector suffers, and of course, vaccine R&D also suffers. So that the point is to continue to push and to engage governments to invest in science and to invest in research, and to link that to, or rather to sensitize government to the value of research. So a lot of governments it's quite clear, for instance, that African governments are now convinced that it's important for them to invest in local vaccine manufacture. So they're convinced that local vaccine manufacturing is a good thing, but they need to understand that to have a sustainable sort of manufacture and development of vaccines, you also need to invest in R&D. So linking the value of research to the goals that governments have is an important way to get governments to invest in research. The other question I think is linked as well, which is how do we get to address vaccine inequities? That's a very broad question, right? It's a very broad question that should be tackled at multiple levels. There are many things that affect vaccine inequity. So for instance, we need, part of addressing vaccine inequity is getting, supporting local vaccine manufacturing again. Making sure that there are alternative points across the globe where vaccines are manufactured, which improves access and supply for vaccines and reduces inequity, and specifically supporting the development and production of vaccines in low and middle income countries. So that addresses vaccine inequity. But there's also issues around, there's also issues around patent protection and intellectual property rights. And facilitating technology transfer. So local vaccine manufacturing is unlikely to work very well if the people that own the intellectual property and the patents for vaccines and technology are not willing to share. So addressing intellectual property issues is one of the ways to address vaccine inequity across the globe. And then there are issues around, governance of some of these mechanisms. So and sort of equitable allocation of scarce vaccines globally, sort of protecting against, vaccine nationalism, or what others have called vaccine apartheid, and so on. So thinking about that governance structure to ensure that there's equitable allocation, especially in the context of emergencies, is again a strategy to sort out vaccine inequities.
Okay, thank you. I will ask John Kitonga to unmute and ask his question, so that I don't miscommunicate his message. And then I will jump to Kennedy, who's asked, thanks for the presentation. Why is it hard for Kenyan research institutions like KEMRI to compete against other world institutions in terms of vaccine production? And Lawrence Okeo has asked, great presentation. Prevention has been shown to be better than cure, both medically and economically. Is it possible to cost hesitancy? That is the layman's hesitancy, health worker hesitancy, and can ROI on advocacy be measured? Thank you. Then maybe I will ask. John Gitonga, if you wouldn't mind unmuting, then ask your question. Thank you.
Thank you. So my question is on one of the there were two things that were mentioned in the presentation regarding the vaccine demands, and that was the private demands and public demands. And from the presentation, mandating the vaccine uptake was considered as one of the way to fix this private demand. So my question is on whether this could have any sort of ethical implication. Over.
Okay, so those are three questions. One question was around research, and I think the question was around how can we get research institutions, so local research institutions across the continent, to compete globally in research and development for vaccines. You know, I think the question is, why is that not happening, and so on. I mean, I think one that's so we do have across the continent, we do have you know, research institutions investing in R&D for vaccines. So this is something that that has been happening. This is something that is happening. So there's research on vaccines and vaccine development happening within the continent. Is it, you know, sort of at the level that's happening in high-income countries? You know, probably not. And why is that the case? Number of reasons. One is what we've talked about earlier, is resources. You know, for research to take place, you need funds, you know, and those funds should either come from government, or, you know, come from sort of external funders and so on. And most of research in Africa is funded externally. So for us to get to the level where, you know, we are competing globally, you know, African governments have to start taking the funding of research seriously. So that's an important aspect. And then the other aspect, again, linked to that, is capacity development. So, you know, developing investing in the development of scientists that can then, you know, channel their efforts on vaccine R&D is also an important thing that would sort that. There was a very interesting question around hesitancy and whether hesitancy can be costed, and whether you know, you can do an ROI on, I think, advocacy. The short, you know, the quick answer is yes. I mean, I think that's a very interesting suggestion conceptually, but the short answer is yes. It's quite possible to do that. Because when you think about vaccine hesitancy does have both costs. Because when you think about healthcare costs are direct costs of using an intervention or consuming an intervention, and also the cost of not using it. You know, so for instance, when people are hesitant to take vaccines, then they are likely to catch a disease, and if they catch a disease, then the disease comes with costs. So it's possible to cost or to determine the cost of hesitancy. And then, of course, it's possible to determine the cost of advocacy. And it is possible to determine the health benefit of effective advocacy. So if advocacy is going to reduce hesitancy, improve coverage of vaccination, reduce prevalence of disease, you can do that. So you can absolutely do a cost effectiveness analysis or a return on investment analysis on vaccine hesitancy. Or other advocacy to reduce hesitancy. There was a question around what was it? Vaccine mandates and the ethical implications of vaccine mandates. So this is there an ethical question? Yes. Is that the same as saying that should it be? No. You know, a lot of the time. So the thing about vaccines is that vaccines. This is what, you know, the use of vaccines. It comes with, you know, and an individual's choice to be vaccinated or not to vaccinate doesn't just affect them. It affects people around them. And so in situations like that, you have to think beyond just individual rights. You have to think about, sort of the benefits and costs to the broader population as opposed to just the individual. And so in situations like that, some of the strategies that I used include, include mandates, which people might say violate individual rights, but others will argue that they have a broader societal benefit. It's the same thing as mandating people to isolate when they have an infectious disease. They're not just doing it for themselves, but they're doing it for people around them. Other containment measures like, curfews and so on. Does it infringe on individual rights? Yes. But do the benefits to the population outweigh the discomfort to an individual? Absolutely. So it depends on where you fall there. It's you can have a long ethical discussion, but there are many situations like that.
Thank you very much. And it looks like vaccine hesitancy is quite a hot topic, because I have two more questions. One from Kennedy is, how do we tackle vaccine hesitancy? Is the mandatory approach one of the best ways to roll out vaccines as it happens in early childhood vaccines? Case in example pertains to the HPV vaccine, which is yet to be fully embraced despite its benefit. And then Farah says, my name is Farah from the University of Nairobi. Thank you, Professor Edwin, for the good presentation. I have two concerns. How can health economics inform the prioritization of vaccines in resource-constrained settings? And lastly, how do vaccine hesitancy and misinformation influence the economic effectiveness of vaccination programs?
Thanks. So there are two questions on vaccine hesitancy. I'll answer them, together. One of the questions was, how do we tackle vaccine hesitancy? I think there are many strategies out there to tackle vaccine hesitancy. I mean, certainly mandating is one of the ways that has been used for certain vaccines. But again, I mean, there's, mandates have very sort of, there are limits to their effectiveness. And so the other strategy is public engagement, awareness creation, advocacy, sensitization, busting those myths that people in societies and communities have and so on. That's also quite an effective strategy to tackle vaccine hesitancy and sort of countering misinformation and addressing the issue around the spread of misinformation and so on. So, those are two strategies. I'm sure there are many other strategies out there, but those are sort of standout strategies that I use to tackle vaccine hesitancy, and they're effective to varying degrees. The other vaccine hesitancy question was around, I think, how does it, correct me if I'm wrong, you can read it again, Caroline, but I think it was about how does vaccine hesitancy affect the effectiveness of vaccines?
Yes, of vaccination programs.
Or vaccination programs. So the short answer, the direct answer is that it reduces the effectiveness of vaccination programs, because to benefit, for vaccines to have optimal benefits, you need to achieve high coverage. So if you're in a situation where, in a situation where you have high vaccine hesitancy, it means that your demand for vaccine is quite low, and so you achieve low coverage, which compromises the effectiveness of vaccination programs. Then there was a question around how can health economics inform priority setting for vaccines?
Yeah.
This is essentially the role that health economics does, which is so one of the ways is to support countries and agencies to make decisions about how to optimize their vaccination programs. So what vaccines to include in their package of vaccines that are publicly funded, and what populations to target with those vaccines, and what delivery strategies to use to deliver those vaccines. And two tools that are quite useful there is one, cost effectiveness analysis. So comparing the costs and benefits of alternatives to identify those that are most cost effective. And here, I mean, identify the vaccines that are most cost effective, identify the deployment strategies, so what population groups to vaccinate that are most cost effective, and identifying the delivery strategies, so what strategies to use that are most cost effective. So one example, how to deliver HPV. Is it cost effective to deliver it through schools, or is it cost effective to deliver it through clinics and so on? So cost effectiveness analysis is an important tool that can be used to inform these decisions, and budget impact analysis. So an analysis of the affordability and the impact of investment decisions, of vaccine investment decisions on country budgets. So those are two tools that would typically be used to support priority setting for vaccines. And what would happen is that you would need a mechanism for making these vaccine decisions. So most countries now have, they're called National Immunization Technical Advisory Groups, NITAGs, that make vaccine decisions. And typically what happens is that you need one of the criteria that these NITAGs use to be economic criteria. So criteria around selecting those vaccines and strategies for delivery that are most cost effective. And you would need them to commission the use of economic evaluation to inform those decisions.
We're going to engage you a little bit more since the questions are just coming in fast and furious. We have a hand up from Tope Olobutun. Tope, do you mind asking the question? As we reach out to him, once he's able to log in and ask the question, we can be looking at the other questions on how, from Tabitha, who's asking, how can we compare the value of different vaccines to be able to decide what vaccines to prioritize for a country or a setting? And that is closely linked to the question by Vicky, vaccine inequalities and economics. How do we balance the cost of reaching marginalized communities who are under-immunized or have high number of zero-dose children?
Thank you. So I think the first question is really related to the question I just answered, which is around how can economics be used to inform priority setting. So like I mentioned, the way to determine value is to carry out a cost effectiveness analysis where you compare costs and benefits. And typically, that allows you to identify the most cost-effective interventions, cost-effective vaccines. Now, if I'm to get to, I assume that part of the reason she's asked that question is, so, we know how to measure costs. So cost is money, money is comparable, so that's great. But how do you measure health benefits? You can, in a cost effectiveness analysis, we typically use what we call generic measures of health benefits. So, and we have two common ones. So disability adjusted life years, which looks at the numbers of deaths that have been averted by a vaccine, and then number of sort of suboptimal, less than optimal quality, so disability of life. So disability adjusted life years. So we add them and we use that to measure health benefits. The beauty of using a generic measure such as a DALI, disability adjusted life year, is that you can compare it for different vaccines. So I think that's what you're asking. The other generic measure is quality adjusted life years, where we look at, instead of looking at deaths averted, we look at improvements in your quality of life. So quality adjusted life years. And again, that's comparable across interventions. So you can compare two vaccines in terms of cost per quality adjusted life year or cost per disability adjusted life year. So I hope that answers your question. There was a question around vaccines and I think vaccine equity. There's a question around vaccine inequalities and tools like economic tools and so on. So you're right. I mean, so this is part of the market failure, right? It's part of the market failure. If we were to leave the distribution, supply and distribution of vaccines or any other health intervention to the market forces of demand and supply, then what is likely to happen is that people will access vaccines based on their ability to pay. They'll access their vaccines based on ability to pay. So if you're richer, you probably come from a more urban area, you're more educated, and so on. You're more likely to get a vaccine, you can afford it, while when you go to marginalized areas, rural areas, poor areas, people will not have that same ability to access vaccines. So then you end up with that inequality where some people, children have access to vaccines and some children do not have access to vaccines. Now, we know that that is not optimal, because if there's a disease outbreak, then it's going to spread beyond those areas. So that's an externality. So the way to sort that out is to ensure that you remove that barrier of access, and this is why vaccines, governments invest in vaccines. So you publicly finance vaccines. Publicly financed vaccines, you make them free at the point of care, you make sure you use adequate or optimal delivery or distribution strategies so that they reach the farthest ends, and then you make sure that you invest in sensitization and awareness to find those people that are hesitant, and try and get them to use vaccines and so on. So it is a market failure. It's a market failure that is addressed by publicly financing the vaccines.
Awesome. So we'll change a bit of the conversation and dive into career paths in this particular topic. And Tope has asked, to pursue a career in health economics as a medical practitioner, would you suggest going through the public health route, that is Masters in Health Economics, or through core economics? And then there's also a question from Sebsil. I think I hope I mentioned that correctly. Thank you for the great session. If one has an interest in merging health economics and vaccinology, where does one start? Are there any existing opportunities for collaboration or mentorship, at least in the African setting? And he is calling in from Eswatini. So those are two questions on potential career paths that one can take. Over to you.
Thanks. Yeah, thanks for that. One was around, so essentially to do a postgraduate training in health economics, you have two broad options. You have schools that offer, a master's in public health specializing in health economics. You have those options, and mostly those are sort of public health schools. They would offer that, and then you have economics schools that would offer health economics as an MSc, a Master of Science, or a master's specialty within economics. Again, it doesn't really. It's a matter of preference. It doesn't make much of a difference. You could do either. The important thing is to get the health economics competencies to apply in the health sector. So whether you get it through the MPH route or through the MSc route, not much of a difference. It's a matter of public preference. And I say public preference because typically, it's public preference and access. So there are certain schools schools of economics that will not admit someone for a master's degree if they don't have an undergraduate degree in economics. Not all schools are like that, but some schools are like that. So if you do not have an economics undergraduate degree, you might face that obstacle applying to certain schools, not all schools, which means then it will constrain you to applying to public health schools. So that's one consideration. The other consideration, and this is why it's a matter of public of personal preference, it depends on how sort of keen you are to sort of do a lot more of the economics, a lot more of the sort of economics module, so heavy economics modules or econometrics and so on. So the MSCs are more economics heavy, while the MPH is kind of are a hybrid. It's more applied. and it includes modules that have nothing to do with economics. So, your epidemiology, public health, and so on. So it's a matter of preference. Some people prefer the core economic modules. Some people prefer sort of a hybrid type approach where you get some public health training and with applied economics training. It's a matter of preference. The other question was around, I think, vaccinology. If someone is a vaccinologist, there's something about how do you get competency in vaccine economics. Again, you could decide, you want to do an MPH, or rather, a master's degree in health economics, and then you develop a specific interest in vaccine economics, and you would get training in that, or you could just, you could do a short course. So there are schools that offer short courses in vaccine economics. So it's possible to do that, to just do a short course on vaccine economics. But I think also the best way to learn things is to learn by doing. So in addition to getting the training, getting involved or working in contexts that require you to apply economic principles to vaccinology questions is another way of developing competencies in vaccine economics. And this context could vary, right? You could work in a research setting and your role is to carry out vaccine economics research. You could work in pharma, and your role is to, to think about, analyzing vaccine markets, pricing for vaccines, thinking about access for vaccines and so on. You could work in development organizations, thinking about, so the Gavis of this world and UNICEF and so on, thinking about how best to finance and deliver vaccines to low and middle income countries. So working in those contexts allows you to develop practical skills in vaccine economics. In terms of opportunities to do that, again, like I said, so you have trainings, and certainly in Africa, we, as Caroline mentioned at the beginning, one of the key strands of this project, this current project, is to carry out vaccinology training. And part of the vaccinology training includes modules on vaccine economics. And we have several other vaccinology courses across the continent that teach on a whole range of vaccinology concepts, including vaccine economics. So those options are there. And I'm sure Carol can talk about other options for mentorship and so on.
Yeah, I will do that. I will make it one better. And what I will do is, since we already have the email addresses of the participants, we can do a comprehensive list of these outfits and share that with the audience so that they're able to have that information. We have two last questions. One from Freddie Kitutu, who says, excellent presentation, Professor Barasa. My observation is that there is nuanced differences in the applications of health economics and HTA in low middle income countries versus high income countries. What are your thoughts about this from your experience and observation? When have low middle income countries found utility for CEAs? And then the last question that we'll take today is from Kennedy Omondi. The session was excellent, Professor. How do we as researchers convince the citizens that our vaccines produced locally are just as effective as those produced outside our country? Over to you.
Thanks. To the last question again, it's so how do you convince the public that locally produced vaccines are as effective as those that are not locally produced? There are very many strategies that one could use. The two that I would like to highlight are one, advocacy sensitization is an important strategy. So making sure that the information is communicated and communities are sensitized about the community is engaged to understand their concerns, and there's again engagement to to sort of improve, or rather to sensitize the populations and to create awareness and so on. So that's one strategy. But the other strategy that is useful is transparency. Transparency and following due process and so on. You want, one of the ways to convince the public that what you're producing is safe is by just following international standards and being transparent about it. So we have international standards for manufacturing and quality of vaccines and so on. As long as the manufacturing processes are following that, and African countries are transparent about that and explicit about that, and they strengthen their regulatory systems to international standards, then that builds the confidence of the population on the vaccines that they're producing. There was a question around cost effectiveness analysis and HTA, and I think the comment was that there are differences in the way they're applied in high-income countries and low-income countries, and what that means. I hope that's how the question was. So the answer is, is yes. There will always be differences in the application of sort of analytical approaches, because you have to contextualize your approach. So that you have to contextualize your approach, and certainly, so I'm quite keen on sort of supporting the development of health technology assessment across the continent. And one of the things that's quite clear is that health technology assessment, or HTA, has to be contextualized within the African context and the country context. You have to make it work for the population, or rather for the countries. So I think that is expected. But the other observation is that you have less of economic evaluation, cost effectiveness analysis, or HTA in Africa or low and middle income countries compared to high income countries. And many reasons for that. One is, again, capacity to do these kinds of analysis. We need more people that are trained to be able to do that. And second, we need the reforms to be in place. We need African countries to start using systematic evidence-based processes to make decisions. And then third, for a long time, especially for vaccines, most vaccines in Africa, in African countries and low and middle income countries, have been funded by someone else. And so because they're funded by someone else, then that someone else determines what vaccines, they have a lot of power in determining what vaccines are deployed in the country and so on. And the country sees less need to carry out analysis at the country level. But we know that Gavi is currently implementing a sort of a transition program. So as countries sort of improve their socioeconomic status, countries are transitioning out of Gavi support, and they are required to increasingly take up the burden of financing their vaccination programs, which means that now they have to seriously think about optimizing their priority setting decisions and using tools like cost effectiveness analysis to support those decisions.
Thank you very much, Professor. And so there's a question here on from Tamirat. I think there's an area of presentation is very crucial for low middle income countries in the Horn of Africa. One question is how the African public health institutions and researchers are capable in delivering postgraduate studies in order to solve the vaccine issues. And Collins has asked, can institutions like KEMRI push the agenda to kickstart more PhD health economic programs that are research-based and can solve our problems as a country? Do you want to take that, or do I take it?
Happy for you to take it, Caroline.
Yes. So
now that you've offered.
So this is something that we're really driving as KEMRI-Wellcome Trust under the Vaccine Workforce Development Program, for which this webinar is one of the platforms that we're using, just to put that information out there. create that interest so that we're able to pull together people who have like-minded interests into systems and programs and studies that are able to address this. What we're hoping is that by 2040, we as a continent are able to actually identify what we need as a country in terms of disease vaccinations, develop what is needed, do the R&D, do all the entire continuum of vaccine production, so that we're not relying on other continents to be able to solve our own vaccination needs. So what I would ask is if you're able to have initiate that conversation from where you are as an institution, as an organization, as an individual, as a student, and use the vaccinology at KEMRI-Wellcome.org email. Reach out to us and we're happy to share more information on how you can engage. And it will also make us know that you're interested in the courses and the internship programs that we are launching, so that we're able to get you as early as possible and onboard you for this process. Thank you very much. And we are at the end. We are at 3:30 p.m. Ladies and gentlemen, there you have it, vaccines and health economics. Thank you very much for everyone in this webinar. Thank you, Professor Barasa, for engaging with us for quite a lot of time. This was quite informative and interactive. A big thank you to the technical team that has been working tirelessly to make this webinar possible. And ladies and gentlemen, keep a lookout for more sessions. This is just one among a very big series of information that we're going to be putting out in the public, where we delve into more interesting topics on vaccinology and different aspects. Before we close, kindly requesting that you take just a few minutes and respond to the post-webinar survey that we have posted in the chat. We would like to hear about your experience so that we're able to make this bigger, better, and more useful for you as an audience, and also to help us in whatever topics we can discuss in upcoming forums. Have a good day. Looking forward to more engagement with you. Thank you.
Thank you.